Welcome. We'll just give a few minutes for more people in the waiting room to join. Good afternoon, colleagues, esteemed experts from all the countries. Good afternoon, good morning, good evening, depending on where you are. I would like to welcome you to another session of the Surveillance Capacity Building webinar series. My name is Dr. Ibrahim Amadou from WHO Afro Nairobi Hub, Technical Officer, Operational Readiness and Border Health. We have a very interesting session today. We have very esteemed experts that will be providing context to all of us. But before we start, I'd just like to give a few housekeeping and information for all of us participants. Next slide, please. So just to go back, please. Okay, now, just to give the context that for WHO and many of our esteemed partners on the line, we do adhere to the code of conduct to enable events in which everyone can participate in an inclusive, respectful, and safe environment. So these are guided by the highest ethical and professional standards, and all participants are expected to behave with this level of integrity and respect towards every participant while speaking as the professionals that we are. Next slide, please. So just a few housekeeping remarks. For this session today, interpretation is available in English and in French. And on the top left, you can see where the interpretation button is. Kindly click and choose the language that you prefer. For questions, please use the Q&A at the bottom ribbon, the tab saying Q&A regarding the topic and presentations. The chat should strictly be for questions regarding ICT or logistics, those technical issues you may want to know, and to introduce yourself. So do not put questions in the chat box. We will be scanning the Q&A for questions that can be answered in that session, and we'll also have a live Q&A session where you can unmute yourself and ask a question. Kindly note, this session is being recorded and your attendance is considered to be consent that you are accepting to be recorded. Of course, all the session materials will be sent to you in English and in French in the days following the webinar. Also, your feedback is quite important to us. A survey will be shared in a follow-up email after the webinar. Next slide, please. For data use, Project ECHO collects registration, participation, questions and answers, chat comments, and poll responses for this webinar and shares them with partners, including WHO. So your individual data, be rest assured, will be kept confidential, but these data will be used for reports, maps, communications, surveys, quality assurance, evaluation, and also to guide and inform new initiatives. Next slide, please. So let's meet our speakers. We have an esteemed team. I will just be saying from what organization they are going to be speaking from. So up to 1600 hours East African time, Dr. Vivian Kuisi from IOM Regional Office for East, Horn of Africa, and Southern Africa will be speaking. She'll be followed by, from 16 to 1610, Mr. Eston Simwaka and Mr. Stephen Poso from MOH Zambia and Red Cross will be speaking on Zambia cross-border surveillance. The next 10 minutes will be from Uganda. Ms. Caroline Akulo Ogwok from IOM Uganda will be speaking on Uganda cross-border surveillance. This will be followed by a 5-minute Q&A, but do recall that I did mention that you could put questions in the Q&A box and they can be answered. Following that, we will have a session that will lead us to 1655 on legal frameworks in cross-border surveillance. This will be a panel discussion. So myself, Dr. Emily Tuhere from Africa CDC, Dr. Hassan Mohammed from EGAD, and Dr. Vivian Kwesi from IOM will be speaking via this panel discussion. And this will be moderated by Hannah Mekonnen Tiezazu from IFRC. This then will be followed by a second Q&A session for 5 minutes before we round up and do the closing. So this is the agenda and the flow of the sessions. I wish you a very, very happy and exciting session. So I'd like to invite Dr. Vivian Kwesi to start sharing her screen and commence the first presentation. Happy session.
Good afternoon, colleagues, and once again, welcome to this webinar. I'm trying to share my screen. Yes. I hope you can see it. Can you see the screen on?
Yes, Vivian, just put it in presentation mode and we can go right ahead.
Okay. Thank you once again. So let's start with this session on strengthening preparedness and response to public health threats at borders and along mobility corridors. As I was presented, I am Dr. Vivian Kwesi. I'm the Regional Thematic Specialist for Migration and Health for International Organization for Migration. I'm based in Nairobi office in Kenya. So regarding mobility and health, what could be the relationship between this mobility and health and what can be the dynamic, how can it be dynamic and complex? So we can explore it from an individual level and also at a population level. At an individual level, the health of a migrant is affected by the circumstances of the migration process along the mobility continuum. Mobile populations are not inherently more vulnerable or exposed to health risk. Rather, it is the conditions in which they migrate, live, and work that influence the health risk. At population level now, the increasing volume, rapidity, and ease of travel can impact public health at a larger scale as mobile population interact with host community within and across borders. So border communities are also vulnerable to public health emergency with international dimensions. So today, a health threat from a communicable disease in one location can eventually pose a health threat everywhere due to increased interconnectedness through travel and trade. Many of these risks are exacerbated by unprepared public health and border management systems. So well-coordinated, system-wide multi-sectoral actions informed by and responsive to population mobility is needed to respond to public health threat. Now, regarding this mobility and health at border, we have space of mobility, of vulnerability. We have elements like point of entries, Let's talk about space of vulnerabilities at this point of entry. Geographical areas and location where migrants and mobile population interact with stationaries, local communities such as where this population live, work, transit, or originate. This location represents an environment that can be conducive to increase health vulnerability, such as outbreaks, due, for example, to crowding and lack of public health preventive measures in place. Now, point of entry is a passage for international entry or exit of travelers, baggage, cargo, containers, conveyance, goods, and postal parcels, as well as agencies and areas providing services to them on entry or exit. This is according to International Health Regulation 2005. So, for example, we have mobility corridors, we have areas of congregation, population gathering, points such as works, places, key hub, including urban spaces, schools, place of worship, temporary residence, or transit depot. So we have many places like that. So we have also border space with vulnerabilities where you can find such challenge. Now, I would like to ask a question to you participants. Based on this description of point of entry, space of vulnerability, the link between population movement and communicable disease, what will be, according to you, the main component of interventions at point of entries and cross-border area or public health threat? If you have some answers, please do response in the chat, thinking about the main pillar in response to epidemic prone disease or communicable disease or outbreak. What about this intervention? What do you think? Which intervention do you think relevant for point of entries and cross-border areas? So I give you a few minutes if you can put something in the chat. Let me look at the chat. I see immunization, excellent. For measles and polio, I see screening and identification of point of entry. Yes, vaccination, good. We have screening, vaccination that comes and coming. Probably we can have other response. Yes, we have rapid screening tests, information, surveillance, risk communication, community engagement, infection prevention control. Very good. So we are almost going to a proper system of surveillance, but located at point of entry. Thank you very much. So I will continue now with the presentation. Okay, so as I was saying, we have almost the whole system of surveillance at point of entry. We have capacity assessment, we have risk communication and community engagement, we have referral, we have infection prevention and control, we have our famous health screening, congratulations, this was the first word that came, we have case management, we have capacity building, we have contact tracing, all of this under surveillance. Once again, congratulations. We continue the session with the cross-border surveillance. This includes both active and passive surveillance, as we said, screening, referral, contact tracing. So The cross-border surveillance is conducted at POE and other border health points to prevent, detect, and respond to public health threats that can cross border. It includes both active and passive surveillance according to IHR. So the main objective to prevent, as we say, or manage the importation and exportation of health hazard, including disease and their agents. Prevent the international dissemination of vectors and reservoirs and the spread of vector-borne disease, detect changes in trends of events at POEs, alert other POEs likely to face the same event, either directly or through national structure as per national or regional practices, inform authorities at POEs and at all relevant levels in the health system and other sectors, and assist them in adopting preventive measures, investigation management, and follow-up of events. We have here a photo from Goma in DRC, for those who knows, of an installation for this streaming. Now, looking at this image, this is part of our standard famous SOPs at point of entry. This is an example of surveillance activity where we have travelers entering, washing hands. Then you have a primary screening with a temperature under 38 degrees. The guy will wash his hand again and then continue the travel. If the temperature is more than 38, then there is another, this meets suspect case definition, isolation, another screening, then referral, then ambulance, and reaching the health unit. So the task of the border staff is to make sure that any suspected case that meets the definition or the case definition reach the nearest health center. Now, what are SOP's plan and guidelines in the context of mobility? Standard operating procedure, plan, and guidelines are institutional and operational documents that provide the practical foundation for communicable disease prevention, detection, and response activities along the mobility continuum. They are ensured within broader public health and border management procedures in a country. Across all of its programming, IOM creates and uses plans, guidelines, and SOPs depending on the context. So we can have SOPs guideline produced by partner to inform technical decision-making and in accordance with national and international guidelines, as you can see. So looking at these SOPs with more detail, as I was saying, this is really critical in terms of managing suspected cases. The relationship between population mobility and health is dynamic, as I was saying. So having this SOP in place and health for health facility and other location is key. Defining roles and responsibilities, formalize standardized procedures with clear information. Where do you go? Is there any a mobile phone number that can be used? Those are elements that shall be taken in account while while preparing these SOPs that must be available at those points of entries. Now, if infection prevention control in the context of mobility, you have the goal of implementing these IPC measures in the context of population mobility mapping to ensure that all healthcare professionals, service providers, and other frontline and development workers can protect themselves, the mobile and migrant population that they serve, and the community from infectious diseases. By implementing IPC, you can help break the chain of transmission of a communicable disease. Unfortunately, we have seen that, especially at the beginning of most of these outbreaks, the health personnel is the first or the most affected one. We have this nice map with this cycle, the existence of the pathogen, the reservoir, then it reached the point of entry. We have the mode of contamination, the point of entry, then the host. So it's a cycle, a vicious cycle, obviously. Now, at POEs, frontline responder play an important role in the prevention of this communicable disease to ensure that mobile population do not get infected, to ensure that persons with a communicable disease do not infect themselves as frontline officials, as well as other travelers, to minimize their own risk of transmitting the virus, protect themselves from getting infected and from further infecting friends and family outside the workspace. This risk can be mitigated by reduced by implementing these standard precautions for IPC, respiratory hygiene, hand hygiene, personal protection equipment, decontamination, waste management. Another measure can be the decontaminations, which refer to the disinfection of all surfaces and the environment to prevent the spread of infections, as well as care of contaminated items. Conducting appropriate personal hygiene, both at home and at the workplace, talking and recommended self-protection measures, living appropriate physical distance, or maintaining a clear workstation that is regularly disinfected. So those are some of the measures that can be, and obviously they are not exhaustive. Now, as you rightly mentioned, we also have as one of the important action taken at point of entries is the risk communication and community engagement. So while dealing with travelers, it's important to share right information. So this involves delivering information to communities about the risk that the population face, and how they may protect themselves and their loved ones. So it ensures that population at risk are well informed on how to avoid infection, prevent further transmission, and seek care. This risk communication and community engagement is an essential component of health sector emergency preparedness and response plan. Effective actions at community level in raising awareness and providing practical advice to affected population helps build trust and improve compliance with public health measures. So this risk communication and community engagement provide, as I was saying, a basis for all other core activities to prevent, detect, and respond to disease outbreak. Once again, this is a core activity or action to prevent disease at point of entries. What can be a mobility-sensitive risk communication and community engagement approach? As we discussed, marginalized population, including migrants or mobile population, can become even more vulnerable in public health emergency due to factors such as the lack of access to information, effective disease surveillance and early warning system or health services. The most at-risk population are those that depend heavily on the informal economy, as we know, occupy areas prone to shocks, have inadequate access to social service or political influence, have limited capacities or opportunities to cope and adapt, and have limited or no access to technologies. You can share information on radio, on television. Do they have access to a television? Do they have access to radio? Even the language that you are using, do they understand this language? So by understanding these issues, we can support the capacity of vulnerable populations in emergencies. So it's important to ensure that mobility is considered in all public health messaging, such that migrants and mobile population have access to timely, appropriate, context-specific, and correct information in language that they understand. As you see, I am really emphasizing on this risk communication and community engagement practice. Here are some ways to proceed, support the translation and dissemination of advisory and public health information, disseminate this information through efficient channel, including NGOs, migrant volunteer or respective communities, advocate for inclusion of non-discriminatory access to public health services, partner with migrants community network to monitor risks associated with human mobility in affected areas, tailor all activities to the context, adjusting for community perceptions, belief, and practice. This is very important. Diversify communication tools and formats, simplify messages, use continued feedback to adapt message to the evolving situation. So those are some ways to go to make sure that this risk communication and community engagement is really mobility sensitive or adapt to mobile population and migrants. Then to conclude, or to finish, not to conclude, let me talk about this important tool that we call population mobility mapping. It's a set of tools developed by IOM to understand population mobility dynamics and characteristics at national and subnational level at point of entries, informal border crossing points, and other locations where large-scale population movement take place. Population mobility mapping gathers valuable qualitative and quantitative data to identify and prioritize locations to strengthen public health emergency response capacities and to inform effective public health actions to prevent, detect, and respond to communicable diseases. PMM, this population mobility mapping, was developed through an adaptation of the IOM displacement tracking matrix that you can access. We have a website that you can also access regarding data for mobile population. This system tracks population mobility for more effective humanitarian response for displaced population. The population mobility mapping exercise are very key for because we use both initial data from this displacement tracking matrix from document, then having all the stakeholders around the population, the participant from the government authorities, the health authorities, to sit and and identify the main point of movement of displacement, and to better place structure or tools for the disease surveillance, especially screening. So in various contexts, IOM has used this this PMM, and this started during the large Ebola virus disease in West Africa. So
Doctor,
for the
please try and summarize. Thank you.
Yes, yes, I am at the end. The recent one, especially for this Mpox disease, IOM use it in DRC, in Burundi, and also in Uganda so far. Now we have this table. You will receive the presentation you can go through regarding the use of this tool for the preparedness, for the prevention, the detection, and the control. So thank you very much for listening for this session. These are the contacts, do not hesitate, and your questions are very welcome. Thank you. Over to you.
Thank you very much, Dr. Vivian. Very, very interesting session. So colleagues, you have heard that migrants, mobile populations, and border communities are indeed a special, very vulnerable group. You've heard that information and other things may not reach them due to language and other barriers like geography and distance, and partnering with networks to get tailored activities for their context is key. I've also heard that PMM is not one tool, but it's a set of tools. So we thank you very much, Vivian. Colleagues, please type your questions in the Q&A, not the chat. And we will, as the panelists go through, I'll be answering. So we quickly call on the next presenter. Please share your screen. Thank you. We will be hearing from Zambia.
Good afternoon. Good afternoon. Are you able to hear me?
Yes, we can hear you. Please, your screen will be in full screen, and then you go ahead.
Okay, thanks. I'm Eston Smwaka, representing Zambia. I'm the District Disease Surveillance Officer for Chiravombwe District. That's my introduction. Next slide, please. Next slide. Yes, so I'll start with the background. And under the background, I'll look at Zambia's points of entry. Zambia has several points of entries. We have international airports, we have border crossing, we have marine crossing, and in these points of entry, there are activities that we conduct, such as screening of travelers. For each and every traveler that is entering our country, we screen all the travelers and all the passengers against cholera, Ebola, Mpox, and yellow fever, and other related infections. Next slide, please. So I'll look at the capacities of Zambia's public health surveillance system, especially with focus on Mpox. And under disease surveillance, we have laboratory capacity. Zambia has a diagnostic capacity at the Zambia National Public Health Reference Laboratory to test for Mpox. So whenever we come across a suspected case, and once we collect our specimens, we have the Zambia National Public Health Institute laboratory. That's where we take our samples. The Zambia National Public Health Institute has developed a national contingency plan for Mpox, which includes enhanced screening at points of entry, the strengthening and constant activation of the Public Health Emergency Center. Yes, stands out as one of the key coordination tribes government and its stakeholders have recorded in their quest to improve. Sorry about that. Then health information, under health information, the Zambia National Public Health Institute uses electronic integrated disease surveillance and response system. So what we mean here is for each and every facility, health facility in Zambia, they are either given a tablet or a laptop. And these gadgets are used for reporting to the next level. So once information is inputted into the system, the next level or the higher level will be able to see what is happening on the ground. Next slide. So under human capacity development, the government has continued to train healthcare workers to strengthen their capacities to detect and respond to public health threats. So with support from the Zambia Red Cross Society, government is training community-based volunteers in community-based surveillance alongside other response packages like risk communication and community engagement. And at the points of entry, in relation to surveillance, the Zambia National Public Health Institute has heightened surveillance at points of entry, including international airports, border ports, and sea entry points. This includes enhanced screening, testing, and vaccination efforts. Key frontline health workers are being trained in both Mpox case detection and management. The early detection of Zambia's Mpox index case is evidence of the ability and alertness of personnel to detect Mpox as it was done by frontline health workers. Next slide. Under strengthening community-based surveillance, with support from the Zambia Red Cross Society, the Ministry of Health, like I said, they trained the community-based volunteers, and these community-based volunteers, they are actually helping us to detect infections early in the communities. Then volunteer network and contact tracing with trained volunteers across 50 branches. Zambia Red Cross assists in public health responses, including contact tracing during outbreaks. When it comes to technology and reporting, electronic platforms enable real-time data collection and transmission with standardized reporting through the community signal form. And coming to community awareness and engagement, the Zambia Red Cross Society conducts educational campaigns to enhance disease prevention, early reporting, and community trust. So, next slide, please. So strengthening community-based surveillance international through technology and training, the Zambia Red Cross Society has strategically invested in technology-driven community-based surveillance by equipping volunteers and health facilities with electronic gadgets that enable real-time data transmission. And these devices help improve the timeliness and accuracy of reporting, ensuring that public health threats are identified and addressed promptly. And furthermore, the NS has prioritized capacity building initiatives, providing training to volunteers, and the Ministry of Health facilitate focal point persons in community-based surveillance methodologies. This training emphasizes the principles of surveillance, including case detection, verification, reporting, and response coordination. Next slide, please. So under cross-border, community-based surveillance, working with the Ministry of Health and the Zambia Red Cross Society, some of the success stories demonstrating the impact of community-based surveillance. We'll start with polio detection in Kalabo. I want to mention that community-based surveillance volunteers were instrumental in detecting a polio case in Kalabo where they actively monitored and reported cases of acute flaccid paralysis, a key indicator of polio. This led to swift action by health authorities, triggering mass vaccination campaigns and heightened surveillance in the region to prevent further spread. I also want to mention that it is through the community-based surveillance system that one of the districts on the Copper Belt, and to be specific, Chirilabombo district, they were able to identify about 60 confirmed cases of measles. And when it comes to acid spillage incident in Chingola, community-based surveillance volunteers played a critical role in reporting an acid spillage that affected several communities. The timely reporting of this environmental health hazard triggered an immediate response from national authorities, leading to community-wide interventions that mitigated the health impact of the spillage. Next slide, please. So what are some of the challenges that we are encountering in trying to implement what I've just highlighted? Some of the challenges is inadequate resources for sample transportation to the lab. Like I said, we only have one accredited lab where we can confirm measles and polio. So all the districts, all the provinces, they have to travel all the way from where they are to Lusaka to submit their samples for testing and analysis. So you can see from that actually it needs a lot of transport resources, then limited resources to conduct intra-response capacity building, training of all key frontline staff in Mpox, limited resources to conduct meeting with gatekeepers and other essential community members in the district, inadequate funds to conduct technical support in the response. The other challenge is inadequate resources for contact tracing, active case search and monitoring and alert verification. So on this one, let me also mention that it has been difficult to do contact tracing to all our patients, all the index cases because of transport challenges. Inadequate resources to conduct RCCE and active surveillance in schools and other congregant settings. Then Mpox training biased on public institutions, neglecting such critical entities as the hospitality, such as hotels, lodges, guest houses, and transport industries. Next challenge, next slide, please. So with that, Chair, I submit on behalf of the Zambian side. Thank you very much.
You made it just on time. Thank you very much. Applause to Zambia. Colleagues, you've heard that community surveillance using technology is key. You've also heard some of the challenges. Please, Zambia, look in the Q&A. There are some questions for you. I'd like to emphasize to presenters, though, please speak at a pace that is a bit moderate so that the interpreters can follow. So please remember, no questions in the chat. Put your questions in the Q&A tab. So we go on to the next presenter. Please share your screen.
Okay, Ibrahim.
All right, welcome. Please put your screen up.
Thank you. Just sharing. Where is it?
Or we can share from the control.
Allow me share from my side. Just
Okay.
picking it. Yes.
Go ahead.
Yeah. Okay. Okay, thank you so much. I hope you can see my screen.
Yes, please go ahead. Put it in full screen.
Okay.
Slideshow.
Yes, good afternoon from Uganda. This is Caroline Nakulu going to share the experience of Uganda implementation at the mobility continuum. So just an overview, Uganda has 65 gazetted points of entry. That includes the airport, airfields,
Caroline,
ground.
we're seeing it not in screen show. Can you put it in full screen? Not in slideshow.
Okay. Is it in slideshow now?
Not yet.
Yes, it should be coming. I've put it in slideshow already.
All right, please go ahead.
Okay. So Uganda has 65 gazetted points of entry, like I've already mentioned, and a number of porous border points, and only 8 designated points of entry. Like you can see from the map, it borders a number of countries with the different border points. So just to mention, the Uganda implementation at the points of entry and along the mobility continuum is mainly governed around 4 strategic objectives. And one is enhancing the evidence based on human mobility dimensions of communicable disease to inform effective prevention, detection, and response. And that includes the mobility mapping, disease surveillance, community-based event surveillance, reporting, and information sharing. We also have building health systems and cross-border health capacities at points of entry, including the host communities, and that encompasses the standard operation procedures, the screening and referrals of travelers, the capacity building of health workers, including the frontline health workers, and infection prevention and control. Then we also have the community engagement and empowerment of migrants and host communities. In Uganda, we don't leave host communities unattended to, because we realize the presence of a number of porous borders that also are accessible to different people who are on the move. Then we have the multi-sectoral partnership and coordination, including the cross-border coordination, not leaving behind the different policies and standards that supports the implementation at the entry.
Apologies for interruption, but it looks like your slides are stuck on slide 2. Can you stop sharing and share on the current slide you're in and put on slideshow, please?
Can the control room share for Caroline? Thanks.
Okay, let the control room share. If mine is not
Amy, can you quickly put up? Caroline, can you tell us what slide number you are on?
number 3.
Wonderful.
Okay, just proceed to slide number 4. Okay, slide number 4. As I mentioned, Uganda does evidence in enhancing human mobility. So we do population mobility mapping to inform the response to different infectious diseases. We did during COVID-19, the current Mpox, and then the current EVD. So when you look at population mobility mapping, we are able to identify the mobility access routes by the different population, and this leads us to different points of entry. We are also able to identify different congregation points that should be targeted for public health interventions. Like, for example, during Mpox, we identified 8 points of entry that were at higher risk, 26 congregation points, including bars, churches, factories, hotels, market, among others. We also identified that Nakasongola had 4 out of the 6 islands that had never received risk communication and community engagement. So this was a very good information to the risk communication pillar for them to target the information sharing. We also realized that some of the IEC materials that were distributed were not in the languages spoken in that community. So they were able to change and give the appropriate messages to their population. We also found that bar attendants were not targeted in all the trainings and the sensitization activities for Mpox, realizing the transmission modes of Mpox to the population, and this was a very good information. The other component we identified was sex workers were being transported to Kampala, which was one of the hotspot locations for Mpox, to Nakasongola on a weekly basis, because the number of men in Nakasongola were more than the number of women. So these sex workers found a niche of offering their services to the population, not knowing the impact of transmitting the infectious diseases. Then we realized that traditional herbalists and shrines were actively involved in the treatment of Mpox patients. Yet, this was a very good niche for the transmission to people who did not have Mpox cases with them. Next slide. So following that, IOM was able to make a number of interventions in terms of the Mpox response, but also other stakeholders came on board and supported the response to Mpox, realizing the different public health gaps. The other component was we look at the capacity building of health, border, and other frontline health workers. So in Uganda, looking at the niche we operate and the number of porous borders, different stakeholders join hands together to support capacity building of border stakeholders. And this is an integrated approach that we use. We incorporate the community-based disease surveillance, alert management, infection prevention and control, as well as screening and reporting of the travelers who are moving. So this is covering both the point of entry and the host communities so that they freely mix with the migrants, but they also have the right information and the right services that they are supposed to access in terms of, especially in areas of infectious diseases. So in a period of 2024, we were able to support over 1,600 individuals, including community health workers, border stakeholders, and frontline health workers in the trainings for Mpox. Next slide. So the other component that we look at is the surveillance at the points of entry and cross-border locations. So we appreciate that surveillance is an integrated approach for Uganda, and not only one partner work on it, it is both partners join hands to collaborate and prevent the transmission of infectious diseases. So this is done at 2 locations, at the points of entry and in the community, especially the host communities. And we use 2 ways of the surveillance. One, we use the digital approach, that is the use of the thermal scanners, which are installed at a number of points of entry, but also we deploy volunteers where there are no thermal scanners and where we don't have permanent health workers to support in the surveillance. Then at the host community level, we do community event-based surveillance where we have the digital platforms to support reporting. It is also linked to the alert management system, and it is directly received at the control center at the Ministry of Health level. So the reporting is timely, including our surveillance at the POE is also linked to the electronic EIDSR tool, which is reported timely at the Ministry of Health. So the coordination is right from the point of entry direct to the Ministry of Health level. So just to share a snapshot, in 2024, we supported screening of over 26,000 people using the IOM thermal scanners and with 30 alerts that were flagged. Then under community event-based surveillance, they were also able to raise over 80 alerts that were responded to and supported through the Ministry of Health structures. Then we also appreciate that during this current SDV, Sudan Ebola virus outbreak, we are also supporting both entry and exit screening. And this is not only being done by IOM, we have a number of stakeholders on ground, WHO, CDC, Baylor, Uganda, including the Ministry of Health. So the most important thing to note in Uganda is that implementation at the points of entry is an integrated approach with a joint effort and collaboration. Everyone appreciates that points of entry is a key area that must be targeted for all the intervention. Next slide. So we also do health infrastructure improvement at the point of entry. We have a number of prefabricated health screening structures at the POE, including the medical tents to support health screening. So you can see in this picture, we have a number of prefabs. This is just one point of entry. We have tents, we have chairs to support the screening. And we also have the temporary holding and isolation facilities. Although right now we are targeting to move away from the temporary facilities and to establish permanent facilities at the POE. Then we also have the disability-friendly ramps and settings to enable all travelers access the services, including screening and hand washing at the POE. Next. Yes, this is just one of the permanent permanent isolation facility that is constructed in a referral facility for a POE at the border of South Sudan. And this was done by IOM with support from EU IGAD. And this is what is being recommended at the Ministry of Health level so that we are prepared at all times to respond to public health epidemics. Next slide. Yeah, Dr. Vivian has already mentioned the barriers we face when it comes to risk communication and community engagement along the mobility continuum. Some of them we deal with the language barrier, the accessibility of the population. So in Uganda, we use targeted approach to implement the risk communication and community engagement. And one, we do the translation of the materials targeting the population and where they are. Then the other, we use the digital platform. Right now in Uganda, IOM has procured 21 TV screens and advertising kiosks. This has been installed at different points of entry to pass on digital risk communication messages in the targeted languages. But also we do community engagements and dialogues with different key stakeholders to reach out to them with the right information. And we also do targeted intervention where we reach out to truck drivers, border in their different stages and where they are found. So we can not only use one approach or one methodology to pass risk communication messages at the mobility continuum. This is very important and we must all appreciate and abide by it if we are to reach out to the right people with the right information and at the right time. So we have some of the figures where Uganda has been able to reach, especially in terms of risk communication. Next. Just to summarize, we have also cross-border coordination where we harmonize a number of things, including the standard operation procedures, the implementation of different stakeholders, and we do planning for the cross-border interventions. And this is one of the key components if we are to move forward. And just for this group that are targeted for mobility continuum, if we are to do joint resource mobilization for cross-border activities and harmonize the implementation at different cross borders, I guess we would go far with our response and preparedness for public health epidemics. As I conclude, in the last slide, we also have some of the challenges that we face in the mobility continuum. One is the limited resources to strengthen POE and cross-border response. We also have limited resource to support interventions along mobility continuum. In Uganda, we don't have permanent health workers at the points of entry. The ministry is just working out that, but we use volunteers at the moment, so which has a high turnover rate, and each time we need to build the capacity since we have different people. We also have once in a while delays in the submission of screening data for areas which are still not digitalized. Then we have gaps, especially in some areas where you find the standard operation procedure in one country is not matching the other country. So there is always a back and forth movement for travelers. And then we have a number of porous borders which still affect the implementation and response to epidemics. Thank you, and over.
Thank you very much, Caroline. We will try and speed things up and quickly pick some questions for our presenters. If you have a question, kindly raise your hand and we will enable you to unmute. While I'm doing that, I see there's quite a significant number of questions in the Q&A for Zambia. I might just read one or two. From Anebo, Zambia, do you have monitoring and evaluation means for community engagement during community-based surveillance? What structures have been involved during community-based surveillance in addition to trained volunteers? Also for Zambia, if you could just take note of these two and then answer the rest in the chat. From Sarah, how does it work with the IT tools to do community-based CBDS if the community volunteers or community health workers are working for or trained by different organizations in different districts, or do they all use one tool? I'll take one. I don't see the hands. I don't see the hands.
Sorry, Chair, you can come again on the questions for Zambia.
Zambia, please, what M&E do you have for community engagement during community-based surveillance, and what structures have been involved during surveillance? Then from Sarah, how does it work with the IT tools to do CBDS if the community volunteers or community health workers are working for or trained by different organizations in different districts? So do they all use one tool? Participants, I'm looking for hands. Your raise hand function is enabled if you want to ask a question.
All right. Thank you so much.
Zambia, please go ahead and Zambia, please go ahead and answer, and then I'll come to the raised hand from Lucky. Lucky, please hang on. Zambia will answer, and then I'll come back to you. Colleagues from Zambia?
Maybe I can still respond. And Eston gets to add. Thank you very much. My name is Apostle Stephen. I'm the Health and Care for Zambia Red Cross. So just respond to the first question. I was talking about the M&E and as well as the structures that we are working with regards to community-based surveillance. Just to mention that we have a National Security Institute, the Health Security Institute, which is ZNPHI, and ZNPHI has a framework on monitoring of surveillance information, as well as coordinating and guiding partners involved in surveillance. So there is indeed a well-defined monitoring and evaluation structure for Zambia, enshrined in the National Strategic Plan for 2022 to 2026, which was also shared in the slides. But when it comes to structures that we are working with in terms of the broader picture of surveillance, so we have the One Health teams that Zambia is working with in country. And so the composition of these One Health teams include all government line ministries and different partners. So in the case of Mpox, the One Health team is working with several line ministries, including Ministry of Fisheries and Ministry of Agriculture, Ministry of Health. We have Ministry of Local Government because of the nature of the disease that we are dealing with. So that's one on One Health teams. Then we also have immigration departments, knowing that we're also looking at cross-border surveillance. So for Zambia, there's a strong commitment to working with immigration departments, that these are people that are receiving or dispatching goods and services at border entry points. And so the deliberate actions of engaging these security wings. In addition, also, we know at border posts or border entry points, we have different security wings additional to the immigrations. So for Zambia, the police or army officers have been engaged to be part of the surveillance tools as they are dealing with different individuals entering or leaving Zambia. We also have community structures. So there are several community structures. We have the toll-free line in case for the Red Cross, where people can direct call. We have the market associations that we're working with. We have also organization working with key populations, as well as the structures that we have in the Ministry of Health called the Epidemic Preparedness and Response Committees. So all these, they work supporting the volunteers. Thank you.
Thank you so much, Zambia. In the interest of time, I will let Lucky and Hassan Swarai ask one very concise question each. Also to Uganda, there's a question around, has there been cross-border transmission of EVD that you may answer in the chat?
All right, thank you, Mamadou, for the excellent facilitation. Well done, our presenters. My name is Dr. Iko Nyari Adebudo. I'm a veterinarian and a field epidemiologist. I work with the Edo State Ministry of Agriculture and Food Security in Nigeria. My question has to do with, deploying standard operating procedure SOP, for cross-border surveillance, when we know in the context of Africa, we have a lot of migration that are along the informal routes. So now, having acknowledged this challenge that we have migrations along informal routes where you don't have formal structure to be able to administer your SOP, for your cross-border surveillance, what adaptation strategies you bring on board to be able to, still do cross-border surveillance, for your migrating population. Thank you, and over.
Hassan, please go ahead. Vivian, I think you will take Lucky's question.
Thank you very much, Mr. Moderator, and I want to appreciate the presenters. Like you mentioned from their presentations, from the Zambia point of view, my own concern is with regards information management as far as One Health is concerned. You and I know that Mpox is a zoonotic, so using the One Health approach, I want to know how are they managing the information, especially when they have so many players. They have the partners at community level, regional level, and national level, and how are the information being managed?
Okay, so to paraphrase, how is information being managed with a large number of players within the field? Thank you very much, Hassan.
Community level to national level.
Thank you very much, Hassan.
You're welcome.
Our colleagues will answer these two, and then we'll move to the next section.
Thank you, Chair. Can we respond for?
Please go ahead.
Thank you, Hassan.
Very concise.
Thank you very much. Thank you, Hassan, for the question. So let me just give you a little bit of some detail on the One Health, especially in terms of their roles and responsibilities. So yes, indeed, it's a big number of people involved in the surveillance, but just to let you know that As Zambia, we are focusing on getting the alerts and turning these alerts for appropriate response. So if you look at the One Health component or the composition, they are focused. Some of the members in these teams are responsible for alerting the system. So for instance, Immigration Department, or for instance, Ministry of Fisheries, their role is to identify in their structure if they see any probable or any suspected case, because they're also dealing with the community. They are reporting to the relevant authority, which is the Ministry of Health. So that triggers appropriate response. So in other words, we are not taking to chance any loophole where a case can pass without being identified. So immigrations, even the police, the soldiers, they know they are offering security, but at the end of the day, they're interacting with an individual. So if they notice any symptoms or anyone suggestive of having a disease of public health importance, they need to report for appropriate response. So indeed, there are those just involved in reporting, and there's a team that takes the action to verify. Thank you.
Thank you so much. And we have heard diseases don't need visas to travel. We also know that the animals like bats don't need visas to travel. So One Health is critical. Vivian, you want to jump in very briefly before we move to the next session, which will be moderated by Hannah McConnell. She looks ready to go already.
Thank you, Ibrahim. I'm answering the question from Lokis regarding points and non-formal point of entries. As you rightly answered in the chat, there we can use the population mobility mapping tool, keeping in mind that the approach is really about surveillance, and usually we try to make sure that population trust the health team. So using this tool, there's a process on identifying routes, the main route that this population takes, using the data that we have, using the information from the population itself, some of the representative of this migrant or mobile population, and to help to better position the screening tools. So once you have the right place where you have the most important flow of population, then you can put your screening materials there and proceed with the surveillance. So this is really about the approach, about using the right key people, and to make sure that the first intention is well known. It is about disease surveillance and only about disease surveillance. Thank you.
Thank you very much. Just a reminder to Zambia, there's a lot of interest in the Q&A in what you have presented. Please go back and answer a lot of your colleagues. So at this point, I will be handing to Hannah to take us into the next session, which is the plenary. Over to you, Hannah.
Thank you so much, Dr. Ibrahim, and good afternoon, colleagues and the partners. I think we have few minutes. We hope we'll get extra time for this session. However, I'll just jump into it. And I would like to invite Dr. Mamadou, Dr. Vivian, Dr. Hassan, and Dr. Emily to be part of this panel. If you could please spotlight these colleagues. The discussion during this panel is going to be about legal frameworks. I think we have seen in the questions so far, and I hope I'm audible. Can you hear me all? Okay, good. So as we have been discussing, there is a need for cross-border collaboration, data sharing, and information sharing, and surveillance in general would require multiple countries when it comes to cross-border. The question I'm going to ask our panelists is, these panelists have come from Africa CDC, IGAD, IOM, and WHO. As leading multi-country, continental, and international organization, you are mandated to facilitate cross-border collaboration in pandemic preparedness and response. What PPR and cross-border collaboration mechanisms and frameworks did you manage to put together, especially after the recent public health emergency of international concern, to ensure there is good collaboration and information sharing? The other question I have for you is, can you please explain to our audience what legal frameworks and coordination mechanisms exist currently that facilitate these PPR interventions? So I would start with the panelist who is the first on my screen, Dr. Mahamadou. If you can please explain and respond and speak to these questions. And just for your information, our panelists will have 4 minutes each to talk to this. And then please, audiences, please put your questions during the discussion so that they can, if they are not able to answer during this panel discussion, then they will be able to send the email and the responses as part of the package. Dr. Mahamadou, please go ahead and speak to these questions.
Thank you, Hannah. Like you rightly said, I'm with the WHO. As many of our colleagues already know, WHO is the Global Secretariat for Public Health and Health Security, which it implements through the International Health Regulations 2005. This evolved from its predecessor, the International Sanitary Regulations. You may also know that all our member states, 194 of them, are signatories to these regulations. And so we implement through our over 150 country offices and 6 regions. We work hand in glove with your ministries of health to ensure that frameworks are in place. So apart from the IHR 2005, we have regional-based frameworks, including the premier framework for surveillance within the African region, which is the IDSR, the Integrated Disease Surveillance and Response. So we like to say IHR is implemented through IDSR, because in any region, your IHR capacities would be manifested through your surveillance and response system, which for the Africa region is IDSR, and some parts of the Eastern Mediterranean region of WHO as well. So we work to build these through our country offices or even regionally from the Africa Regional Office. The most recent that we've worked collaboratively on is actually the Africa CDC's framework for information sharing, which was released last year, alongside many of the other partners on this panel. So these frameworks usually utilize the obligations of member states to the global collective. So in IHR, Article 5, 6, 8, 9, 10 to 13, Annex 1A and 2 talk to obligations of member states, including sharing information and notification. Also, for implementation, you would be looking at boosting your capacities, and you may know that the joint external evaluation second round is ongoing as using the new JEE 3rd edition tool, and this seeks to boost your IHR capacities both in Annex 1A and B, and then in the Article 19, 20, and 21, which are obligatory for member states. Well, around the challenges that we have, you do know that there is a very little amount of knowledge, unfortunately, we've seen within our countries around border health and cross-border surveillance, especially around border health and POEs. I tried to describe it to a colleague recently, even within the organization, and it's like the elephant that somebody touches the side and thinks it's a wall, somebody touches the back, the tail, and thinks it's a snake. The person thought this was just community health work that is applied. No, unless you think the whole world is just one community, it is really across every aspect of IHR capacities. So we also know one of the challenges is now a very shifting global financial landscape. However, there are opportunities, things like the pandemic fund, recent rounds give us opportunities for strengthening this knowledge. So I'll stop here and I'll hand back to you, the chair.
Thank you so much, Dr. Ibrahim. I will then also ask the same question to Dr. Mohammed, Dr. Hassan Mohammed, and then please followed by Dr. Emily, then Dr. Vivian. If you could please go in the same order and continue responding to the question from your organization's perspective. Over to you, Dr. Hassan. And especially, Dr. Hassan, if you can highlight the role of IGAD in ensuring the implementation of the IHR and also the data sharing. Over to you.
Thank you very much, Hannah. And as you've rightly put it, my name is Hassan Mohammed. I am at the IGAD Secretariat and I'm the cross-border health expert. As you know, IGAD is a member states organization comprising 8 countries in the Eastern and Horn of Africa. So we are a regional economic community that has, a vast number of pastoralists who are moving across the borders and who actually have no regard for any formal crossing or any, point of entry. They will really move with the animals and cross the borders and, get to the next country where there is, pasture and water for the animals. Having said that, we recognize that, disease does not care about borders and that anytime these people cross, diseases are bound to cross with them. So we coined a word for these people, including, the people who are moving with the animals, the people who are crossing for trade purposes, the people who are laborers crossing borders, and we coined the word cross-border mobile populations. That is what we call those people who frequently cross borders. So in view of this, I think IGAD decided that we must take deliberate efforts to ensure that, we have a health system that is responsive to these people. And towards this, I think one of the things or the frameworks we developed was actually the IGAD cross-border health policy. Again, this policy speaks to cross-border because, again, I think it's a very important component in our public health system. And I probably suspect it could be the weakest link in our pandemic preparedness efforts because, again, these are facilities that are not well equipped, that are not well staffed, and surveillance efforts in these cross-border areas are actually suboptimal. So we developed this policy, and we said that we have to make deliberate efforts to invest in these cross-border facilities. So what are we doing? We are building capacities in the cross-border areas to ensure that there is enough capacity for surveillance. We are trying to develop laboratory capacities in these cross-border areas, and we have not left out the community component. In the community component, we've actually partnered with organizations that have a presence on the ground. That includes, IFRC and the federations. We've also partnered with IOM, as the presenter before us had indicated. So at the cross-border areas, we have tried to make sure that we have coordination platforms that bring together people from across the borders. And these people will include people from security, will include people from immigration, the process will actually be led by the Ministry of Health. So we are bringing together these people to discuss issues of health. And one of the things that they are going to discuss is surveillance issues. That is one. The second framework probably I would like to speak to very quickly is the data sharing and protection policy. You will see the cover of that policy at the bottom right of the screen now. And we actually realized that without a policy on data sharing, we will not be able to have a regional, surveillance system. And we decided that it will be a good time now to actually make this policy. What this policy does is it actually details how countries are able to share policies, what data is going to be shared, whether it's going to be patient data, whether it's going to be aggregated data, whether it's going to be granular data, and it speaks to how this data is going to be shared securely, and how we will be able to ensure that we have an interface between the different countries. Thank you very much, Hannah. Back to you.
Thank you so much, Dr. Hassan. Colleagues and audience, please continue to put your questions in the Q&A. And Dr. Emily, over to you, please.
Thank you very much, our moderator, for today. So in terms of Africa CDC's contribution in the area of strengthening cross-border surveillance and information sharing, we all appreciate that we have had a history as a continent of, having a challenge of multiple disease outbreaks. And of course, as earlier said, these do not require visas to cross international borders. And what we have learned from the so many outbreaks and epidemics that we have responded to previously on the continent, when it comes to multi-country coordination and collaboration, we noticed a trend of sort of an ad hoc approach towards supporting interventions. We do always come in a reactive mode when an event has occurred, and that is when we are swinging into action and beginning to put in place some temporary structures for coordination and collaboration. We also noticed that we have a gap, especially in the way that we are supporting the African Union member states in terms of the different partners that are supporting in the different areas. And so this disjointed effort was really not helping us in terms of galvanizing the support that member states are receiving across the board. And of course, limited capacities for information sharing, as seen in the JEE reports that are regularly released through the WHO. So because of this, Africa CDC, drawing from our mandate on the continent, we decided to go ahead and develop a continental strategy for coordinating cross-border surveillance, information sharing, and collaboration. So this strategic framework essentially addresses itself across 6 strategic areas. We call them 6 pillars. And these include the area of coordination and collaboration strengthening, focusing mainly on the aspects of governance and financing for cross-border surveillance. The strategic framework also addresses itself to the area of technical and institutional capacity building, particularly for POEs. And we also address the area of mechanisms for public health information sharing. And of course, this takes along surveillance data sharing across different countries. The other strategic pillar, which is pillar number 4, looks at strengthening early detection of public health events across borders. And this aims at strengthening surveillance and laboratory capacities at POEs. Pillar number 5, which focuses on risk communication and community engagement, including social mobilization, goes without saying that the communities that are involved, either in the migratory communities or the communities that live along these borders, need to be mobilized. And so the last pillar, which is pillar 6, addresses itself to strengthening the monitoring and mapping of population mobility patterns and dynamics. Well known that these are some of the factors that really contribute to spillovers when it comes to either hazards or public health events crossing borders. So this continental strategic framework is not sort of a one-man show or a standalone document, but it focuses and employs a multi-sectoral approach that involves all the key stakeholders and partners on the continent. So taking, for example, the partners represented on this call, and of course, all of our member states have been part and parcel in the development process of this important policy document. We do recognize the role that the regional economic communities play in strengthening cross-border surveillance networks and establishing information sharing platforms. So aside from that, we continue to collaborate with all the key stakeholders, and I think today is a very good demonstration of one of the collaboration areas that we are working on. And Additionally, I just want to speak to the fact that as Africa CDC, our organization is structured that we do have regional collaborating centers or coordination centers in the different regions of the continent. And these act like our legs and arms on ground to collaborate closer with member states. So in this context, we have also developed a very, very important platform that I want to speak about here, which is the regional surveillance networks. We call them RISNet in brief. And these regional networks bring together a caliber of special or technical personnel from the member states to discuss and devise means of how to address surveillance-related needs and gaps within the countries. So I just want to speak to this for now, and also to mention that over and over again, we do get to convene high-level leaders from countries, ministers of health, in other times, different high-level senior officers when it comes to coordinating and bringing countries to work on collaborative frameworks. We do have a lot of policy documents, ministerial declarations that have been done along this particular area of intervention. And as I said, we do not work in isolation. We do work in collaboration with all the key stakeholders on the continent. I'll stop here for now and hand over to you, our moderator. Thank you.
Thank you so much, Dr. Emily. I'll just go back now to Dr. Vivian. IOM is one of the technical organizations who deals directly with the mobile population. I think you would be one of the beneficiaries of these frameworks, and you will be, you are probably engaging with many stakeholders when it comes to dealing with the mobile health. So I just want to ask you, which main organizations do you deal with when it comes to pandemic preparedness and surveillance in cross-border areas? And what kind of mechanisms exist for these collaborations? And which frameworks do you usually use? If you can please give us practical examples of how you make reference to these tools in the legal instruments and how you facilitate the cross-border health, and what kind of mechanism exists for you to coordinate and to collaborate between different countries? Thank you, Dr. Vivian, over to you.
Thank you, Anna. As IOM, allow me to remind again, IOM is the International Organization for Migration. Our main target is migrants, it's mobile population, it's also host community along mobility corridor, along the mobility continuum. So there's a wide range of stakeholders which are involved in public health preparedness and response along the mobility continuum within countries, across borders, or among partner agencies. We can start with the partner here, especially WHO, Africa CDC, International Federation of Red Cross, regional economic communities like EGAD, like East African communities and others. Across border, this includes national authorities communicating with their counterparts at multi-country and regional level, and coordination mechanism, including, as I was saying, regional economic communities, among others. We have partner agencies, I was saying, and looking at the way to do the collaboration means a set of arrangement and action carried out jointly by different actors on both sides of the border with the aim of improving the capacity to prevent, detect, and respond to public health. So this collaboration includes, for example, surveillance of diseases and other events that may constitute public health emergencies, harmonization or monitoring method approaches or tools, information exchange mechanism, it can be formal or informal, mechanism for facilitating and providing quality care to cross-border population, the pooling of health resources on both sides of the border, cross-border collaboration strengthen and enhance existing capacities in cross-border. Now, regarding formal tools, let me talk about the health mobility the health mobility management framework. Based on our experience during Ebola virus disease from 2014 to 2016 in West Africa, then it was revised to reflect this experience based on the COVID-19 pandemic. And this framework is now operationalized for the prevention, detection, and response to communicable disease in the context of widespread and multi-directional human mobility. So this framework has 5 main pillars, which almost cover all the response, mainly based at point of entry. For those who knows, dealing on point of entries can be very challenging. Working at an airport, in an airport, you have like somehow some facilities available, but being at a ground crossing point, very far from the capital, from the cities, with a lot of logistic issue, you find yourself almost delivering the whole package of a health system. So the strategic objective of this health border and mobility management is first about enhancing the evidence base of the human mobility dimension of communicable disease to inform effective prevention, detection, and response. Then it's about building health system and border health capacity at point of entries and along the mobility continuum for communicable disease prevention, detection, and response. The third objective is about enhancing community engagement and empower migrants, mobile population, and host community in communicable disease prevention and response. The fourth one is about promoting mobility sensitive and inclusive policy, legal, and strategic framework. That's where we have our SOPs, we have our public health emergency response plan and other documents, and even country strategic plan where this population is well mentioned as one of the target or beneficiaries. Then the fifth objective is most cross-cutting, strengthen multi-sectoral partnership and coordination, as we are doing here, all of us together, and see the complementarity, the synergy among us. Thank you very much. I won't be long. Over to you, Anna.
Thank you so much, Dr. Vivian. Yes, I think you touched upon so many important issues when it comes to cross-border surveillance and cross-border PPR intervention and services in general. I think these were also raised in the Zambia's presentation, where the remoteness of the cross-border areas is one of the key challenges when it comes to PPR and services, essential services. So we can understand all that issues, and thank you so much for these responses and for this for speaking to these important points. I think we are running out of time, and we have so many questions in the Q&A, and I'll pick a couple of them so that the panelists can respond to them. One of them is, what mechanism exists for timely and secure data sharing between countries? So I think IGAD, I think this is related to what you mentioned about the policy. If you can please speak to this, and if there is secure mechanism. And other colleagues also, if you have something, please respond to that. And then I will move to the next one.
Thank you, Hannah. And I think the major reason why we develop this policy is to answer such questions. One, I think what is agreed between the countries is that any data that is going to be shared between countries is actually going to sit at IGAD. And I think that is one of the things that actually made the countries to allow us to have a policy like this. And this policy has actually been endorsed by many of the countries in the IGAD region. The reason being that any data that is going to be transmitted will not go to another country, but it's going to be sitting with IGAD. Of course, we have other arrangements. We have issues around confidentiality. We have issues around, protection, data protection laws. We have aligned this policy with the data protection laws in the different countries. And we made sure that only information that or data that is needed is going to be shared between the countries. For example, we have developed a referral tool between the countries. And this referral tool actually was a paper-based previously, but for now it is going to be, online tool. So what we are going to do is we will make sure that only information that is required by the other countries to make decisions on patient management is what is passed on to the other countries. And then we have made sure that we employ the security measures the best in the world and ensure that this data cannot be breached. Thank you very much.
Thank you. If you can continue with the same regarding IGAD data sharing policy, I think it is more or less related. Is it only guidance with hopes that member states adapt? What incentives, if any, need to be used if alignment is not yet to the level of expectation? If there are incentives and if member states have already aligned and approved that.
Yes, and actually, one of the things that, as I mentioned, we were working on is actually a referral tool for TB patients across the borders. One of the things that was happening across the borders is that we had a very high rate of loss to follow-up. And when we came together as countries mentioned that they really need a way of tracking these patients across borders. We developed this tool. This tool has a feedback loop to the referring facilities. And one of the things that the countries have now told us is that actually with this kind of mechanism, they are able to track patients, see treatment outcomes for patients across the borders. And I think this is really helpful. One of the other things that we are doing is we are actually trying to operationalize a regional, surveillance system that brings together, pulls data from the different ministries of health. And in real time, countries in the region are able to know what is happening in the other region. So there's a lot of motivation to use this. And I think countries have bought into it. Countries have adopted actually this. And again, from the start, this was a consultative process. The development of the data protection policy, data sharing and protection policy was actually a consultative process. And the inputs came from actually the member states. And this is their document. Thank you.
Thank you. There is one last question. It is probably not very much related, but I will read it anyways to Dr. Ibrahim, if you may. There is a question from Henok from Ethiopia. Are there any, sorry, let me just get it back. Are there any actively ongoing surveillance activities that are conducted in Ethiopia on Mpox that Africa CDC, Afro WHO would support, and how would you support these surveillance activities in the wildlife and at border areas? So if you can please respond to this in general terms, if not specific, please.
Okay, thank you for this question. I will highlight in three answers. Number one, we have a collaborative mechanism of both Africa CDC, WHO, the Joint Action Plan under the flagship initiatives, which PROS, TAS, and SURGE. So the TAS especially, Transforming African Surveillance Systems, deals closely with surveillance strengthening. Also under One Health, we are looking, you may be aware that the quadripartite organizations, WHO, FAO, WOA, and UNEP have several tools, including bridging workshop, including joint risk assessments, including multi-sectoral coordination mechanisms for One Health. And these are all targeted towards strengthening close collaborations between organizations. And I'm sure if you would reach out to your Ethiopia WHO office, you would get more information on these supports. The third thing I'd like to mention is, as WHO Afro, we're also putting out very soon a framework on IHR aspects of POE and surveillance. Now, this document is going to highlight several of the things that many of our organizations do support within the region. And so from this perspective, I do believe you can get supported. Also, the last thing I'd like to mention is, please, a reminder, pandemic funds are utilized to strengthen mainly One Health surveillance. And I'd like to call on many of your countries that are recent recipients or in the process of developing pandemic funds applications, that cross-border surveillance really is key in your applications. The diseases these days do not respect these borders, and we must show solidarity all together to try and protect each other within our region and thus globally. I'll stop here and hand back to you, Hannah.
Thank you so much, Dr. Mabdu. I see one important question. However, I think we are out of the allotted time for us. I don't know whether it is okay to highlight it, or I think it can be responded to via email. It is about interoperability of surveillance tool between animal and human health. So I will leave it up to you. Interoperability is crucial for data sharing between animal and human surveillance system, with continental operability not yet fully operational. To what extent can a One Health approach be effectively implemented with cross-border surveillance systems? So I think you can respond to it via email, or otherwise, I think we thank you so much for the presenters, and thank you so much for the active Q&A. I think I will give the floor back to you, Dr. Mahmoudou.
Thank you, Hannah. Apologies for not unmuting in time. I was also trying to respond to that last question. It's a very key question. I want to thank all colleagues that managed to join this session. Just one or two things. Our team will be sending you all the PowerPoints and the recording of this session on several platforms, and including the previous session and including a session we had earlier on POEs and border health in the context of filovirus outbreaks. It will be useful to listen to. Other thing I've mentioned in the chats is that WHO Afro is also trying to push out a coordination framework for border health in relation to IHR, which will be shared with your member states soon. So we're going to have more sessions regarding community surveillance, and look forward to having all of these colleagues. We want to appreciate the countries that joined. We had Ethiopia, we had Zambia, we had Nigeria, we had DRC, South Sudan, Kenya, Cote d'Ivoire, the Gambia, South Africa, Uganda, Guinea, and Zimbabwe online. If more countries have joined, we really appreciate. We apologize, we can't call all of you, but we really appreciate your attention, and please continue to reach out. We will give as much information as possible to strengthen each other. Thank you, and have a good evening to all of us.
Thank you so much, and have a good night.